Hello, everybody. My name is Claude Scheidecker. I'm a clinician caring for people who use drugs. I'm from Basel, Switzerland. More recently, I have been involved in programs aiming at the control and hopefully elimination of blood-borne diseases in Swiss prisons. We will chair together with Dr. Jackie Richmond, this session, which is called Models of Care in Hepatitis C. And without further delay, I would like to ask our first speaker, which is Ms. Andrea Herranz-Monchales. Ms. Monchales will present the Hepatitis C Free Balears project, a hepatitis C model of care adapted to people who use drugs in Spain from the Balearic Island. Please.
Is it working? Okay. Good afternoon to everyone. As he said, my name is Andrea Herranz, and it's a great pleasure to be here and to present our work, which is titled the Hepatitis C Free Balears Project, Hepatitis C Model of Care Adapted to People Who Use Drugs from the Balearic Islands, Spain. First of all, I wanted to begin by acknowledging and thanking the people who use drugs from the Balearic Islands who have generously participated in this research. These are my conflict of interest, the funding statement, and also the content of the presentation. So, as all of you very well know, globally, the hepatitis C virus infection affects about 58 million people. And one of the groups most at risk of infection is people who use drugs. Some of the reasons of this high risk include that they can suffer from stigma and discrimination, often have an unstable life situation provoked by their socioeconomic and demographic characteristics, and also by their prioritization for drug use. Also, the former or active drug use is another of these reasons for high risk of hepatitis C infection. People who use drugs often have difficulties accessing healthcare, causing lack of screening and also lack of treatment. And this lack of screening can lead to lack of hepatitis C status awareness among this group of patients. In addition, the healthcare system of Spain can cause a stigma among a specific groups of patients. Their services are mostly centralized, often involves waiting lists and multiple visits to providers. And by and large, the hepatitis C standard model of care can be complex. So the Balearic Islands are an autonomous community in Spain, which includes the islands of Mallorca, Menorca, Ibiza, and Formentera, and has a population of around 1.2 million inhabitants. According to the hepatitis C prevalence data of the Spanish Ministry of Health, about 1,350 individuals live with untreated hepatitis C in this region. Therefore, adapted models of care are needed. So our proposal was the Hepatitis C Free Balears project, which offers an alternative hepatitis C model of care with simplified screening, diagnosis, linkage to care, and treatment pathways tailored to people who use drugs living in the Spanish Balearic Islands and using a microelimination strategy. So between April 2021 and April 2023, this model of care was implemented in 21 addiction centers, including addictive behavior units, NGO centers, social inclusion centers, a prison, and a mobile methadone bus. And in addition, all 6 public hospitals of the islands were involved. In this model of care, social and healthcare providers of the addiction centers and public hospitals were coordinated, and all collaborated between them in order to ensure the effective operation of the entire process. So the model of care included 4 phases. Phase 1 was the Phase 1 was the recruitment and on-site hepatitis C screening, and it was done by using a rapid HCV antibody test called OraQuick. If the result of this test was negative, information on hepatitis C prevention measures was offered to participants. And if they had a positive antibody result or had a previous hepatitis C diagnosis, the dry blood spot or DPS test was performed on site to confirm hepatitis C viremia, as well as HIV and HBV serology. Okay, phase 2 consisted of linkage to specialist care for those participants who need it or ask for it. And in phase 3, only for those participants who had a positive DBS result, treatment prescription via telemedicine was done by the pathologist. And with prior participant authorization, treatment was shifted from hospital pharmacy to the addiction center, where it was given to participants who need it. And finally, phase 4 consisted of the on-site monitoring of sustained virologic response at 12 weeks after end of treatment, and also reinfection monitoring after a year, using the DBS test in both situations. Okay, so let's talk about results. Overall, 1,423 participants were recruited in the addiction centers. 33% of them were anti-HCV positive, and 12% of the total population, which is 170 people, had active hepatitis C infection. The sociodemographic characteristics of those participants with active infection were as follows. 73% were male, and the mean age was about 47 years old. Roughly 90% were Spanish-born. 18% had unstable housing situation. About 60% lacked basic studies and were unemployed. Almost 30% reported psychiatric disorders, and the two most common reported infection modes were drug use and sexual practice. Regarding epidemiological characteristics and substance use, we can see that 86 of these participants with active infection already had a previous hepatitis C diagnosis, and 21% a previous treatment. 45% reported active drug use, and 11% active alcohol consumption. About 50% were under opioid substitution therapy, and 16% also had HIV infection. So, of those 170 participants with active hepatitis C infection, 86% initiated treatment, and of those, 84 finished it. And here it is important to remark that in those participants reporting active drug use or active alcohol consumption, there were no significant differences on treatment completion compared with those with no active substance use. Okay, so of those who finished treatment, 77% had a monitoring test after 12 weeks at the end of treatment, and 93% of them achieved sustained virologic response. And after 1 year, diagnostic tests were offered again to participants, especially to those who continued with risky practices and to those who were treated. But of the 1,400 overall participants, only 821 were eligible for retesting. And the reinfection monitoring test was performed on 11% of them, and 4 reinfections were detected. So to conclude, I would like to emphasize that with this decentralized model of care, diagnostic tests, linkage to specialist care, and hepatitis C treatment are facilitated, which enables high cure rates among people who use drugs. Also that routine hepatitis C screening must be offered and performed in all the addiction centers of the Balearic Islands in order to achieve the elimination of the infection in this high-risk population. And finally, that this decentralized model of care should be implemented in the healthcare system of the Balearic Islands as an alternative pathway in order to ensure that healthcare is equitable for all populations and to eliminate hepatitis C.
Thank you very much, Ms. Pochalis.
I'm one slide. To finish, I would like to thank all participants again, also the entire team and professionals of the Hepatitis C Free Balears project, as well as the entire health system research group at ICE Global. Thank you.
Again, thank you very much for sharing this interesting data. There is the option of questions and answers from the audience. Maybe I would like to start. An impressive 21% of those included in this study have been treated before inclusion. Were those essentially reinfected, or did you have treatment failures in your populations and the issue of resistance?
We don't know, but we mostly are reinfections because we have reports of some of those that were already treated, and we know that finished treatment and they were cured, so we assume it's a reinfection, but no, we don't know in all of them. Yeah. And
related to that question, 1 year after treatment, you had a very low rate of reinfections, about 5% or so, partly explained by the low redetection rate. Do you expect to extend the check of reinfections?
Yes, already we now are looking for more funding, so we want to continue with the project, and the main objective is to retest all of these who were treated and who have risk of reinfection. So yeah.
And my last question would be: are all patients retreated after reinfections in this system?
I don't really know now, but
basically.
Yeah, some of them were, but the others, as the project ended, so we don't have a follow-up of them, but yeah, some of them were.
Claude, can I ask a question? Andrea, thank you very much for a great presentation. I'm interested in the duration of time from testing to the linkage to care. Mm-hmm. You're an island, so people can't get away from you. Are you able to engage with them, and how is it a swift process to get into care, or?
It's an easy process because we have a very good communication between the addiction centers and the hospitals. So we could coordinate it very well, and we facilitated the visits and the consultations, so without the waiting list. And in general, it was easy, but it depends on any case. Yes, in each case.
A good partnership between all the services working together. The partnership is strong between all the services working, which is great. Thank you.
Are there more questions from the audience? Doesn't look like. So at this stage, thank you one more time. At this stage, I unfortunately have to announce that the second presentation that was planned has been cancelled yesterday. It was Dr. Kau's presentation from India. I just make sure that Dr. Kau is not among us. It doesn't seem to be the case. So we don't know the reasons for this cancellation. We hope that Dr. Kauer and her family are well, and we all wish her all the best. So the next speaker will be Dr. Bao Wu, who is the Senior Technical Director overseeing HIV, TB, and viral hepatitis programs at PATH in Vietnam. His presentation is entitled HIV Integrated Approach to Accelerate Hepatitis Testing and Treatment Among People Who Use Drugs in Vietnam. The floor is yours, Dr. Wu.
Hello, everybody. I'm Bao Wu from PATH Vietnam. I'm going to share with you the HIV integrated approach to accelerate hepatitis testing and treatment among people who inject drug in Vietnam. So this is the context of Vietnam. Vietnam estimates 6.6 billion people living with hepatitis B and 907,000 people living with HCV, and ranked fifth of the top 10 countries with the highest mortality rate from the hepatocellular carcinoma. However, 80% to 90% of people living with HBV and HCV remain undiagnosed, and less than 30% of those eligible enroll on the treatment. Key population, particularly people who inject drug, are most affected by HBV and HCV as well HIV. So the low uptake of HBV and HCV services due to the lack of dedicated funding for hepatitis, passive testing approach, and lack of diagnostic testing and treatment service at the primary healthcare facility, and high cost of the testing and treatment, and low social health insurance coverage, for the DAA, and also among the population, target population, there is a limited awareness of the disease, and also low political will for the hepatitis elimination. The question is how to accelerate achievement of micro-elimination of hepatitis among people. So in this context, we implemented the HEPLINK project. This is a 2-year initiative funded by the Hepatitis Fund and implemented by PATH in collaboration with Ministry of Health that aim to accelerate HIV test, HBV, HCV testing and treatment through among the key population including people who inject drug, through the integrating hepatitis testing and treatment with harm reduction and HIV service in Vietnam. We implemented this project in 2 high-burden cities, Hanoi and Ho Chi Minh City, during 2020-2022. So what is our model? We implemented the integrated care model. We engaged 9 PWIT, community-based organization, providing the community-based screening for the HBV and HCV, and 18 facilities, including the methadone maintenance treatment clinic, ART outpatient clinic, and also a PrEP, KBLAT private clinic. They will provide systematic screening for HBV and HCV, and using the rapid diagnostic test, and making different or linkage to the diagnostic testing, viral testing, and also the treatment. And this model enables active screening and timely access to the hepatitis diagnosis and treatment for the key population, including PWIT. So in this presentation, I will share the result among the PWIT we implemented from April 2021 to July 2022. And in this slide, you see that we reached about 8,403 PWIT. Out of them, 88.4 opted for HBsAg testing, ending with the 10.5% positivity rate, and 70% of them eligible, enroll on the treatment. But we see the gap here is the access to the viral load testing. Only 38.5%, receive the viral load testing, HBV viral load testing. So this slide shows that, community-based, testing model detected higher HBsAg positive rate, while facility-based testing was the more successful with linkage to the HBV treatment than community-based testing. So the factor affecting with the HBV infection among the PWIT, including the age from the 45 years old, and uptake of community-based testing, and PWIT to using PrEP. So the integrated model also increased HCV testing uptake and treatment initiation among the PUID. And this slide, you see that 91% of PUID reach the uptake, the anti-HCV testing for screening HCV, and the positivity rate about the 19.7%. And similarly with the HPV, we also see the gap in terms of access to the HCV viral load testing. But the good thing that the 83% of those eligible for the treatment, they are initiated with HCV treatment, and this also thanks to the Global Fund support for Vietnam to provide the free HCV treatment for the PL-HIV and also PUID. So this slide, we see that unlike the HPV, the facility-based testing detected a much higher HCV seropositivity rate and was more successful in linkage of, to the HCV confirmation and treatment initiation than the community-based testing. So the factor associated with HCV infection among PUID also includes the age from the 45 years old and uptake of facility-based testing and PUID living with HIV and the PUID using PrEP. So PUID client also perceive the benefit of the integrated care model, and with this model, they are being awareness of the the prevention, and also they see the convenience to have HIV and HCV testing at the same time, and they also encourage their peer to get the tested early. So in conclusion, key takeaway message here is a paradigm shift from the fully vertical to an integrated health system response. And we have learned that integrating viral hepatitis into harm reduction HIV service is an effective approach to accelerate access to HPV, HCV testing, diagnosis, and treatment among PUID. Community engagement is critical to generate demand for and increase uptake of HPV, HCV testing and treatment services. Decentralized and integrated HCV treatment to the ART methodological facility was feasible and effective for expanding access to the HCV treatment among PUID. During our project time, we have global fund supported for HCV, and the government of Vietnam offer the HCV treatment at the ART outpatient clinic, and it's very successful. And HIV integrated approach provided a great opportunity for PUID infected HPV to access tenofovir-based ART PrEP regimen that is also effective for HPV treatment. However, simplified model of care are urgently needed to address the barrier to access to the HPV, HCV viral load testing and treatment for PUID. So what are implication and future direction? So when we see that the Hepling resulted in several firsts in Vietnam. The first time HCV treatment for PL-HIV and PUID is funded by Global Fund since 2021 and continue 2026. And the first time HCV treatment was decentralized and integrated into the ART outpatient clinic in Vietnam, and they are going to provide that service. And the first time also the National Action Plan on the micro-elimination of viral hepatitis among key population is developed and led by VIAC, this HIV program. And the ongoing effort, we are implementing HCV self-test testing integrated into harm reduction and HIV service in Vietnam. We supported from UNITAID through PSI and PATH. And we are also implementing HCV SCV combination prevention in PUID in Vietnam with support from the UNITED and other partners. So with that, I would like to thank to the Hepatitis Fund for the very fruitful Catholic funding and other donors such as USAID, PEPFAR, UNITED, Science, and Abbott Laboratory for co-financing. And thanks to all organizations and individuals listed here. So for more information, please also refer our publication in the Clinical Liver Disease Journal for your information. Thank you for your attention.
Thank you, Dr. Wu, for this very straightforward and clear presentation, and a special thanks for having kept the time. So again, we have the possibility of questions and answers. Again, allow me to start. According to your data, Dr. Wu, the major gap in your cascade seems to be the linkage to care, since only about half or less than half of them needing workup will be linked to care. Could you develop on that issue, please?
Mm-hmm. Okay, thank you very much for your comment and question. I can share with you that, for the, access to the viral load testing for HBV and SCV still, some kind of, the challenging in Vietnam, because that service only available at tertiary, hospital, and we had to refer, client there to get the tested, yeah. And that's also suggesting our ongoing effort to decentralize and implementing the point of care viral load testing, and also suggest the lesson learned from the HIV program, which will draw blood sample from the district level and refer blood sample or transporting the blood sample rather than referring client.
Dr. Wu, were there peers involved in the delivery of this model of care? Or peers, people with lived or living experience?
Yeah, you can see that in this project we engaged, 9 PUID community-based organizations.
Okay.
Yeah. They are doing many jobs in terms of, demand creation and also providing the late testing. Yeah. Because that we engage them, from the HIV program, we already provide the late provider testing, and we train them to provide HIV. Now they integrated with the SCV and HBV screening.
Okay, wonderful. Thank you.
I think this is all. Thank you again, Dr. Wu.
That's right. Hi, my name's Jackie Richmond. I'm a nurse and I work at the Burnett Institute in Melbourne, Australia. And it's my great pleasure to introduce my colleague and friend, Alex Wade, who is a clinical nurse consultant from the Mid-North Coast Liver Clinic, which is a beautiful part of the world in New South Wales. They say the most temperate climate in the country. And she's such a temperate personality, so she suits it well. She will be presenting to us today on assertive outreach, a key approach to achieving challenging Hep C elimination targets, an assertive outreach model of care. Thank you, Alex.
Thank you, Jackie. And I can mostly blame Jackie for being here, actually, being encouraged always to put forward what we're doing so we don't keep what we do to ourselves. And I'm trying to follow through with that, nerves and all. So here I am. I would like to disclose, and I realise I hadn't put it in my slides, that I have the great privilege of being here on an INSU scholarship, and for that I'm incredibly grateful. So I looked at titling this, and really it's about meeting people where they're at, because that's where they're at, interestingly. So this is to give you a bit of an idea where I'm coming from, because we're not in Australia here, and you may not know what New South Wales even is. So we're split up into states. Australia's that little orange place down the bottom there. New South Wales is over there, and that little spot there is actually my LHD, our local health district, and it looks like this. These are our Aboriginal names for those areas, and I have clinics at these places: Port Macquarie, Coffs Harbour, Kempsey, and a little town, looks like it's outside of my area, that I've kind of siloed in. I've brought in a satellite, and that's Grafton. The north coast of New South Wales is home to about 520,000 people, and historically we've delivered care in an outpatient tertiary setting with specialists and appointments and GP referrals. And in 2020, in response to a couple of things, one being COVID, another being I expanded where I was working across that region, and also we thought we weren't actually keeping up with WHO's elimination targets, and we needed to look at something different because all the people who were going to come to us that had been waiting for treatment had already come, and we needed to find another way. And so we started to develop and implement the decentralised assertive outreach model to improve access to Hep C treatment and testing and treatment. The model's multi-dimensional, and I think that's really important. I'm not going to just deliver one sort of care from this model. We have to look at so many different ways of reaching people. It's responsive to the needs that we're finding along the way. And it's predominantly for those who are quite vulnerable in our community, disenfranchised or don't access healthcare ordinarily. And it complements our hospital outpatient facility. We don't just leave that behind. We need to keep doing that. It's a mobile and flexible service delivery. We engage with people who are using drugs or who are experiencing homelessness or are at risk of homelessness. We also have NSP involvement, and we work strongly with our NSP team, and also people who have been in jail or coming out of jail through community corrections. It's an outreach, so in our outreach assessments, they'll include a needs assessment. What is it that you actually need from us? How can we help you? We test using whatever modality is going to work in that setting. Sometimes in a homelessness setting, we'll do dry blood spots. Sometimes we might do point of care. And other times they say, can you just test me for everything? My veins are okay. And so we will. We carry all of those things with us, and we will treat with the DAAs. We're very fortunate that we have a pharmacist champion, and we love this man. So I asked him for a photo so I could get him out there, because he does creative accounting with the dispensing fees in Australia so that our clients get their medication for free, and he will keep a track of when their medications are due. Our consultations, as I say, they're individualised, and we do incentivise. We provide a thank you for the time for people who come and screen with us, and sometimes that might be a work development order which helps people work off their fines. Talked about that earlier today. It's multidisciplinary but also interagency, and so we do work very closely with other services. That's my team. I've actually got a photo of the team there. Nurses, admin, nurse practitioner. Our assessments, as you can see, assertive outreach takes up a lot of our time for assessments. When people are coming into our outpatient setting, they're being referred in. So it's a no-brainer, it's easy. And so therefore, we're getting a lot more treatments through our outpatient setting percentage-wise, because that's why they're being referred to us. But if we weren't doing that much effort for the assertive outreach, we wouldn't get that 40% of people treated that are on that chart. So it's, it's interesting how many people we would be missing. As far as SVRs, I remember being at a conference many years ago and Margaret Hallard said something about SVRs are for us, not for the clients, and I've remembered that, because if I can help people through treatment, they're probably cured. And if I can catch them for their SVR, I will, but often I won't, they'll be gone. So I just kind of hope that that's the case. But we do try to get our follow-up blood tests when we can. Excuse me. And what I found interesting is I actually expected to see a lot more loss to follow-up in our assertive outreach, but it really wasn't that much different. And the only time we had no SVR was because the medications hadn't actually been taken. So very quickly, I think we need to meet people where they're at, which seems a no-brainer to me, and utilise whatever methods we can to get there. We need high screening numbers now. For us in Australia, I have to maybe screen 30 to 40 people to get 1 or 2 positives, and that's in that particular environment. We're looking at vulnerable and stigmatised populations, and it's really important we've heard a lot about language and getting in at the same level as people and treating people as people, and to have compassionate, assertive outreach. So, and beyond, and that's our blue van, our big blue van, affectionately called the BBV, out on a trip back from a residential correctional facility out at a place called Ballunda in northern New South Wales, which is right out in the middle of nowhere, and there's a beautiful river there, which I actually camped at one night whilst doing outreach because I could.
Thank you very much, Alex. Don't run away. Oh my gosh, she's trying to run away. Any questions? We must ask her a question now that she's tried to run away. That is only just... Claude has got a question.
Yes, maybe this question. One imagines that many of the individuals traced in this program pop up in several services, varying over time and varying from person to person. How do you deal with that issue? Do you have a central service for each of the patients? Who is the leading service, in other terms?
Well, there isn't. We are. So we have outpatient service. So I have 4 sites basically, and a nurse will work from one of those sites. And on any given day, she may be doing a doctor's clinic, a specialist clinic where they're seeing patients come in, because we also treat people with hepatitis B. We also look after people with advanced liver disease. We also look after people who have developed liver cancer as a result of their advanced liver disease. So we have a range of other things that are going on here. And one day they might be doing a doctor's clinic, next day they might be going up to Ballunda or out to community corrections or over to the homelessness service. So we have actual clinics that they're running from, and they will do coordinated care from that place. And there's nurses at each site that will do that work. Does that make sense?
I think so, thank you.
Alex, I'm interested in the area that you work in is a regional part of Australia with some very small towns where everybody knows everybody's business. How do you overcome stigma, or have you found stigma associated with Hep C and injecting drug use to be a barrier to accessing your care and assertive outreach?
Yes. Our van, the van used to be white, and we have a very high Indigenous population in the area that I work in, and it was repainted blue. Even still, I've had comments that it looks like police blue in Australia. So they're a little uncomfortable about the van coming in at times, and if we go into communities, I've had comments, why are you targeting us? And we just sit down and have those conversations the best we can. Look, we're going to lots of places. We're trying to help bring the service to people. If you don't want to see us, I completely understand that. So we do have that come up from time to time, but generally now what I'm finding, because it's been a few years, is, and I've heard this in other people's talks, the blue van turns up and people go, oh, they've got some equipment, let's go and set, because we're also a secondary NSP, we also travel with naloxone, I also carry wound care, I carry feminine hygiene products, I carry some food vouchers, I carry a whole bunch of stuff in the van, and that's known. So, yeah.
That's great. And also, I always love seeing multidisciplinary teams at work, and I love the fact that you've got a photo of a pharmacist next to a photo of a pharmacist. That's just fantastic. And the pharmacist, where is he based? And does he service all 4 of your regional clinics?
He would like all of your scripts, please, and thank you very much. He says to me, I want all of them. I don't want any leakage. And so he's actually based in Coffs Harbour, which is at the sort of top part of our LHD. But we actually, when we go into the northern district, we send him those scripts electronically. We also send them, so he will take any remote consult scripts that we do. So when a patient doesn't see a specialist, which is most of the time, most of our clients, most of the work we do is fully nurse-led and nurse-prescribed, just saying. He will take all of those. So, and then he keeps an Excel spreadsheet and he follows up the clients. He is just an angel.
Fantastic.
Yeah.
We all need one of them in our
Yeah.
lives. Fabulous. Thank you, Alex.
Thank you.
I'd like to now invite Professor Judith Feinberg from West Virginia University in the United States. There she is on my screen up there. Hello, Judith.
Okay, thank you very much for inviting me to do this presentation on behalf of my colleagues at the West Virginia University and the West Virginia Rural Health Association. So the Rural Health Association has received funding, educational grants to support this endeavor. So the context is that in the United States, we're not doing very well with getting people treated. This is data from the CDC that shows the proportion of people depending on their insurance who actually initiate treatment for hepatitis C within 12 months of their diagnosis. And you can see we're not doing terribly well. And in West Virginia, where 90% of the people with hepatitis C would be covered by Medicaid, you can see that that is the lowest proportion nationwide. So driven by the injection opioid epidemic, West Virginia has consistently had the highest or second highest rate of acute hepatitis C in the entire country for over a decade, which means we have the highest or second highest rate of chronic hepatitis C. And West Virginia is a largely rural and very medically underserved state. Access to care is very limited. There's pervasive poverty, there's poor health literacy, and there's very limited access to transportation. Additionally, there are a few specialists in the state, none in rural areas, and so it's imperative in order to increase access to hepatitis C treatment for this disease to be diagnosed and dealt with in the community. So we developed the West Virginia Hepatitis Academic Mentoring Partnership, or WVHAMP, as a training and mentoring program that empowers primary and addiction care providers to manage and cure hepatitis C in the community. And our overall goal is to establish a network of clinicians who are trained and supported by Hep C experts who can manage both adults and children across the entire care continuum from screening to cure. So our model of care is as follows. It's free, it's web-based, a training program. We hold it quarterly. We actually started in person, then the epidemic of SARS-CoV-2 happened and we transitioned to web-based and we've stayed there. The key thing is that it's combined with a customized web-based data system that facilitates case-based bidirectional communication across the cascade of care. So starting from choice of initial therapy all the way through cure. And this informatics platform winds up very important. It's the key piece of this model, and it supports shared decision-making. It fosters a learning network for care and increases clinician self-efficacy and efficiency. Because these are individuals, of course, who have never even screened, not to mention treated hepatitis C before. They have ongoing access to Hep C experts, and this in turn enables patients to receive care in their community with providers they already know and trust. And here, this diagram shows you what the training and mentoring process is. We do a full day training to start, after which we call our participants WVHAMP scholars. They can start submitting consultations. They're supported by bi-monthly evening webinars. About 6 months later, we do a half-day training on more sophisticated topics like extrahepatic Hep C and treatment of children and adolescents, and the bi-monthly evening webinars continue. And throughout this period, Scholars evaluate patients, submit consults, get feedback and mentorship, and develop increased self-efficacy and efficiency, and are able to share their experiences with their peers. This is what the electronic consult process looks like. The primary care addiction care provider completes a form on a REDCap database. REDCap is an initially NIH-funded data collection system. The faculty get an automatic email alert that there's a new consult to review. We go in and review that consult. We may wind up answering questions that the clinician poses. We may ask questions based on the data we see, and we ultimately will approve the choice of medication. And this form can be downloaded as a PDF and submitted to the insurer. It can also be downloaded and inserted in the electronic medical record so that the entire evaluation for hepatitis C is in one place in the EMR. So here's our outcomes after 3.5 years. We've trained 176 clinicians. We've trained more than that, but these are the people who are able to prescribe. There's 78 physicians, 86 nurse practitioners, and 12 physician assistants. As of the end of September, we had received 1,207 consults from 69 clinicians, almost a quarter of whom are addiction care providers. It turns out that the patients being seen are referred more than a third of the time, which means our trainees are being recognized as experts in the community. Okay, here's what it looks like from the patient perspective. The median age is 40 with a range of 22 to 79. A little over half are male. A very small proportion are HIV co-infected. The vast majority are treatment naive, and we have 25% is genotype 3, which is very common in West Virginia and a typical pattern for our state. Almost 84% have a history of injection drug use, and 62% are receiving treatment for substance use disorder. Only a small proportion, 4.5% and 6%, have F3 and F4 fibrosis, respectively, and this reflects the fact that the opioid injection epidemic and the hepatitis C that followed it is relatively new in West Virginia. We do not have that many people with advanced disease, and almost everyone is insured through the government, primarily Medicaid. In terms of outcomes, as of the end of September, we have 429 patients who have completed therapy, reached the time point for determining an SVR12, and 422 of them, or 98.3%, have achieved cure. And this, I think, pretty clearly demonstrates that with appropriate guidance and support, clinicians who have never previously treated hepatitis C can achieve the same rate of cure as specialists. So I think it's clear that this program, WB HAMP, is improving access to care in underserved rural communities with very high rates of injection drug use. I think this model can be readily expanded to underserved urban areas. And this approach we have recently adapted to train and support rural providers to diagnose and manage hepatitis C because, sadly for us, according to the CDC, West Virginia is their area of greatest concern in the United States for new outbreaks of HIV. So I am happy to take your questions, and thank you.
Thank you, Judith. Any questions for Judith? It's a fantastic model, and I think the results speak for themselves, Judith. So congratulations. It's great to see you bringing new providers into this space. Do the doctors, the nurse practitioners and the physician assistants, are they able to advertise or promote their hepatitis C interest? I think you said that, that a lot of them are getting referrals in.
Right, so some of we actually track where the referrals come from. The majority come from, they're almost all practicing at what's called a federally qualified health center. which is a federal government assisted program for people who are or underinsured. The majority of the referrals come from inside their healthcare system, so they develop a reputation among their peers. But they also get referrals from outside providers, from syringe service programs. Patients can self-refer, and from addiction care providers who are not themselves treating hepatitis C. And I don't know that they specifically advertise, but we share, with their permission, we share their names and locations with the Bureau for Public Health, and people can access, that information either from us or from the Bureau for Public Health to find people in their community. There are 55 counties in West Virginia, and we have trained providers in 33 of those counties and have received consultations from people in 29. So we are reaching a little bit more than half of the counties in the state.
That's fantastic. And I love the fact that you've got a list so that people can access reliable, up-to-date expertise. Any other
thank
questions?
you.
Claude?
Thank you, Judith. I understand that the population you present to us is really hard to reach. Nevertheless, you are highly successful since you will reach SVR rates of approximately 50% in a couple of months or so. What about the other half? Are they still under treatment, or will this be the second half which will remain hardly to reach? Thank you.
So that's really just a snapshot in time where we were after September. We, on a rolling basis, accumulate the outcomes. So we hope that from the outset, we've had a 98% plus cure rate, and we are hoping that everybody who gets treated through this program, almost everybody, will do well. We've had we've had 7 treatment failures, and we've had 3 reinfections out of these 1,200 plus individuals. So, we hope to accumulate more and more information over time.
That's great. Thank you very much, Judith, for joining us. Thank you.
Thank you.
And our final presentation this afternoon is from Jane Babaraz from the Division of Internal Medicine and Geriatrics at the Oregon Health and Science University in the US. And Jane is going to present on the development and evaluation of a hospital-based Hep C treatment program for people who use drugs. Thanks, Jane.
Thank you for this opportunity to speak with such an amazing collection of panelists who are doing really instrumental work. I'm going to be talking about something on a much smaller scale, a pilot program that I launched in June of 2022 that essentially disrupts the outpatient outreach model and instead focuses on in-reach to patients who are hospitalized who are using drugs using a telehealth or telemedicine model. So the question really becomes, why did we feel like this was necessary? A collection of colleagues of mine, infectious disease specialists, did a retrospective chart review at our university for patients who were admitted for bloodborne infections. And they found that of those 48 who were HCV viremic and were referred for outpatient treatment of hepatitis C, at 2 years, 85% of them still had not completed any treatment. So we knew that there was a linkage to care gap that was desperately needed to be addressed. And in the process, we also learned that there were several barriers that were involved in their lack of accessing outpatient care. Many of us have talked about the importance of a continuity of care program and addressing the social determinants of health. And when patients were leaving the hospital, they had no safety net of encatchment for them. In addition, we found that placing a referral is simply not enough. Our pharmacists did an internal QI project. They increased the rates of referral by 300% for these patients and increased the rates of treatment by 0%. So that's simply not enough. And then in the United States, there was a major cultural aspect that I want to share, which is that our model of insurance really creates a conditions practice among clinicians such that hepatitis C is seen as an outpatient-only treatment paradigm. And we sought to really disrupt that by creating a model of a multidisciplinary team where we had a pharmacist, a social worker, an addiction medicine specialist, and myself. And an electronic health record generated a report for us whereby the patients who were actively viremic and admitted either to the emergency room or hospital would get triggered. I would review their charts quickly for eligibility. My social worker, who was the program coordinator, would subsequently meet with the patients in their hospital room, talk about readiness for treatment, ask about a 16-domain questionnaire of social determinants of health to see what the patient actually needed to succeed in treatment. Then I was telemedically beamed into the room by video to conduct the teleconsultation. Our directly acting antivirals were prescribed, and our outpatient pharmacist would actually found a solution to get the medicines into a pharmacy out of the hospital and then have them delivered to the patients in the hospital to bypass certain insurance barriers. And then we had outpatient telephonic and sometimes in-person outreach through the pharmacist and our social worker to maintain engagement and care. So this is a diagram of our outcomes. I do want to provide the caveat that several of our patients are actually still actively in the cascade, so these results are changing by the week. But the key findings that we have thus far are that more than 60% actually had a teleconsult with me within 3 days of enrolling within the program. 76%, meaning 19 of the 25 that we had a targeted enrollment amount, were started on treatment. As of today, 56 have completed treatment and 11 have documented cure. And we still have 9 that are in the care cascade somewhere. So they've either completed treatment and are still awaiting their SVR or are in the process of completing treatment. And if they complete the program, we'll be looking at an 86% cure rate for these patients. We've only had 4 losses over the losses to care over the total of 12 months of follow-up, which is pretty huge for these patients that we saw most of the time did not even follow up with an outpatient provider. And perhaps most importantly for my patients, the social determinant of health outcomes were huge for them. So 9 actually achieved housing just in the duration of our program. We've had 7 that were connected to substance use disorder treatment. 8 of them established a care with a primary care provider, whereas they previously had none. So I really want to emphasize that using a telehealth model for hospitalized patients is not only an efficient means of providing care to some of our most vulnerable patients, but it's also seemingly effective. But that you do need a pharmacist, a social worker, or in certain cases, a peer, if that's how your models of care are operating, in order to maintain continued engagement and care. And I do also really want to thank those living with hepatitis C who took a chance to be enrolled in this program. So thank you.
Thank you, Jane. That's fantastic work. As a nurse, I'm wondering, there's no nurse involved in this model of care. Is that something that you'd like to explore, or do you think the social worker is performing that task, or?
So that's a very good question, and our addiction medicine team actually utilizes a nurse for the patient education, all of the harm reduction, and our social worker case manager was trained by said nurse. Okay. So the nurse is not included in the program pathway, but she was instrumental in its design.
As is always the case. Yeah. Biased. Any questions? Claude,
Yes.
you're very good.
Yes,
You've done some homework.
Last question from my side. As a physician and clinician, I wonder how you manage to motivate those patients to care for their long-standing chronic hepatitis C, or even start without delay the treatment, whereas the primary interest of them is to overcome the complication that led them to hospital.
The most amazing aspect of this is that most of these patients were extremely ready to start treatment. And in fact, us doing the in-reach and asking what were the barriers to them completing treatment in the outpatient setting had been that my life was too chaotic, and being in an acute care setting where the focus is my health makes this seem possible. And so really the motivation aspect was inherent to the patients we were seeing, and most of them did wondrously and maintained significant contact with our caseworker throughout the entirety of the program. So there was very little motivation that was required on the team's end.
And do the merits come to the social worker or maybe the peers?
Can you repeat that?
Do the merits for motivation and for success come to the social worker or rather to the peers?
I would say the social worker and the pharmacist have been instrumental. The amount of outreach that they do upon discharge to make sure that the patient feels like they have a home that is carried with them from the hospital to outpatient was huge.
Yes, Alex.
I'm really interested in the linkages through when you looked at the determinants of health, and bravo, that's something I've written down as part of assessment to actually look further into that and how to, I'd love to talk to you about that form that you've got, that people were linked into housing and also linked into tertiary or primary health care. How did you go about that with the linkage to housing?
So because we prioritized right at the initiation of the enrollment, the social determinants of health, my social worker from the outset was essentially tasked with this pretty gargantuan mission of trying to, alongside their treatment, connect to outpatient community resources. We ourselves had a system on the inpatient side of the hospital to provide prepaid phones, to provide motel vouchers for those who are unstably housed as a transition from inpatient to outpatient. So you utilize some of the existing inpatient resources, and at the same time you prioritize this as fundamental to their treatment pathway. So the pharmacist is calling to check on adherence. The social worker is calling concurrently to ask about, have you completed your intake for this inpatient substance use program you said you were interested in? So we essentially made sure that the social determinants of health were on par with conversations about adherence and adverse effects, because they're instrumental for the patient's continuity.
Thank you, Janet. I just love that too, Alex, the social determinants of health as an outcome. Fabulous. Kevin.
Hi, yeah, I just had a quick one. How long was the initial hospital stay when the treatment was initiated, before they?
Oh, before enrollment in the program?
And how long were they actually in the hospital prior to being discharged, on average?
So we ran the report 3 times per week, and so essentially most of the patients were being identified within 24 hours of their admission, so pretty rapidly. In terms of the duration of hospitalization, that varied dramatically because the report was flagging viremic patients, but it was not flagging whether they were actively intubated. It was not flagging whether or not they were encephalopathic and unable to engage. And so some of these individuals were in with an injection drug use related infection that had only a 3-day turnaround. And so we would have to prioritize seeing them as a high-risk candidate in the beginning. And then others were hospitalized for 3 weeks. So they may have gotten directly observed therapy for 2 weeks as part of the program, which was an additional fringe benefit of identifying quickly that essentially we were doing DOT even though it wasn't one of our primary outcomes.
Thank you very much, Jane. Thank you to all of our speakers. thank you for giving us an extra 7 minutes. I'll take that as a bad chair. But I think you'll agree that they were some absolutely fascinating presentations and wonderful to see such breadth of models of care being rolled out across the world. So thank you very much for all our speakers.